Hello, everyone, and welcome to our second screencast lecture on Introduction to Blood. So when we left off the last time, we were talking about the blood clotting cascade, and I asked you to review the video under Videos and Animations. So now that you've seen that video, we're ready to move on from there and begin to talk about some clinical significance of knowing and understanding the blood clotting cascade. And I want to talk about a couple of coagulation tests. These tests are used to measure the ability of the blood to clot and measure how long it takes for the blood to clot. Now, there are two tests that we'll take a look at here. And the first one is called prothrombin time, or the PT or PT/INR. Prothrombin time, or PT, is used to check whether the medicine that is given to prevent blood clots is actually working. So let's say, for example, we might have a patient who has atrial fibrillation. The atria just quivering instead of contracting forcefully. So that quivering can cause blood to swirl and to pool and can cause the formation of blood clots, which can then exit the heart, travel into the coronary arteries or other tissues further away, like the lungs, the brain, so on and so forth. So to prevent the blood from clotting, patients may be administered a drug, let's say like warfarin, to reduce the chance of clotting. Now, the way that warfarin works is by increasing the prothrombin time, making it harder for the blood to clot, therefore having less of a likelihood of blood clotting occurring. So the prothrombin time then is a test that's going to evaluate the extrinsic pathway of coagulation. The reference range for prothrombin time is between 12 and 13 seconds. So it should be 12 to 13 seconds that it takes for the extrinsic pathway to occur. Now I have up here /INR of 0.8 to 1.2. INR stands for the International Normalized Ratio. And here's the reason for INR. When the blood is drawn and the prothrombin time is tested, various labs can have variability in this reference range here. So to eliminate the variability, we have the INR. So this is converted then to an INR, and the INR should be between 0.8 and 1.2. That accounts for variability between different labs. Okay, so a high INR then, if we take a look at it from that standpoint, the International Normalized Ratio, is going to indicate then a higher risk for bleeding. In other words, the blood is going to clot more slowly. So that means that whenever bleeding does occur, it's going to be much more difficult to form that clot and to stop the flow of the blood or have hemostasis occur. But from a standpoint of blood clot formation, if you have a patient who has atrial fibrillation and you're trying to avoid blood clot formation, then having a higher INR is going to be good because that's going to make it less likely that blood clotting will occur. Okay, on the other hand, a low INR suggests a higher risk for developing a clot. In other words, blood will clot more easily the lower the INR is. So, for example, patients with atrial fibrillation given warfarin, we want to do a prothrombin time to check what their range is for the formation of blood clot. We'd like the range to be somewhere between 2.0 and 3.0. But with that high range, the blood's going to clot more slowly. But on the other hand, if a patient's having surgery and bleeding is going to occur, it's going to be much more difficult to stop the bleeding from occurring because the blood doesn't clot normally. So we'd want to try to bring the INR down, and we usually So for patients who are taking warfarin, they're going to have to go off the warfarin, and we're going to wait for and do the PT test and wait for that INR to come down to, well, a good INR might be 1.5 for surgery. That would be considered acceptable. Okay, so a little bit about prothrombin time or the PT/INR and its significance. A second test that we take a look at is the partial thromboplastin time, or PTT. This test is used also to check whether medicine used to prevent blood clots is working. But this test, instead of evaluating the extrinsic pathway, evaluates the blood clotting from the perspective of the intrinsic and common pathways of the coagulation cascade. When we take a look at partial thromboplastin time, the reference range now is going to be between 60 and 70 seconds, and we don't have an INR for this. But it should take between 60 and 70 seconds to complete the intrinsic and common pathways of the coagulation cascade. So we have intrinsic and common, so we're going to have a little bit longer in terms of seconds. So what does that mean? Well, then a PTT, and this again is often done in combination with a PT, the PTT, if the result is greater than 100 seconds, that would indicate spontaneous bleeding or indicate more difficulty in terms of clot formation. However, if the PTT, let's just go back here. If the PTT then would be in the 60 to 70 second range, then we'd have normal clotting. And if it was below 60, then we would have uh, uh, even easier clotting, and that might create problems for the formation of blood clots in the body. So we want it to be 60 to 70 seconds. Higher than 100 seconds could result in spontaneous bleeding or difficulty in clotting. Below 60 seconds means it's much easier for the blood to clot, but that necessarily wouldn't be a good thing. We'd have formation of blood clots. We don't want them throughout the body and creating clots that could travel, get stuck in blood vessels, and cause aneurysms, strokes, so on and so forth. Okay, so two important tests. This slide, I think, might be a little bit out of order. This kind of goes backwards. This is just a slide associated with the platelets. In this slide, we can see various types of formed elements here. We can see red blood cells. We can also see various white blood cells. What kind of white blood cell would this be right here? You remember? That's a monocyte. Remember, you have a large nucleus that's kind of horseshoe shaped. That's characteristic of a monocyte. As compared to, if we take a look at this one over here, we have a large nucleus that takes up almost the entire cytoplasm, but we don't have this indentation here. We don't have the horseshoe shape. So this would be a lymphocyte. And then we finally can take a look in these cells or pieces of cells represent the platelets or the thrombocytes. So just wanted to add that and throw that slide in there for you. Okay, next up, I'd like to talk a little bit about blood typing and transfusions and the significance of blood typing in transfusions. Before we actually get into it, there are some important terms that you need to be familiar with. The first of these terms is antigen. An antigen we usually think of as a foreign substance. Oftentimes, it's either a complex carbohydrate, a polysaccharide, or it can be a protein. Whichever it is, this antigen is something that stimulates the immune system to respond as something foreign entering the body, and usually something foreign is going to mean problems for the body. So the immune system responds by trying to eliminate this antigen or this foreign substance. Another term associated with blood typing transfusions then is an antibody. We'll talk more about antibodies whenever we get into the immune system, but antibodies are proteins that are made by the immune system in response to the presence of an antigen in the body. Antibodies have the ability to bind to specific antigens, and when they do, they can neutralize those antigens. The next term we have that's important is actually the term blood transfusion. A blood transfusion is the transfer of blood from one individual to another individual. So when we take a look at blood transfusions or a transfer of blood, we have to pay attention to antigens and antibodies. So here's a chart that I think best explains what our concerns are whenever we talk about blood transfusions. At the top of the chart here, we have various erythrocytes, red blood cells, and these various erythrocytes are demonstrating the types of antigens that they may have present on their surface. Now, we normally think of antigens as being something that's foreign. These antigens are present on the surface of these red blood cells of different individuals. Why are they called antigens? Well, it'll have to do with the transfusion. If we transfuse red blood cells, if we transfuse blood into an individual from one individual to another, these surface proteins on the red blood cell may become antigens to that receiving individual. So that's why we refer to them as antigens, even though they are part of the red blood cells. So with regard to these antigens, we classify individuals as having either type A, type B, type AB, or type O blood. An individual with type A blood will have these surface proteins sticking up off the red blood cells. And these surface proteins, we're going to show them as little spheres here, we're going to designate as A antigens. Another individual, though, may have red blood cells with different proteins sticking up off their surface. They may have B proteins, or then what we refer to in regards to blood typing is B antigens. They don't have A, they express a different antigen, a different protein, we'll call it B. Some individuals on the surface of their red blood cells will express both of these antigens on their surface, these proteins. They can express both the A and the B proteins. While still other individuals who would have blood type O would express neither the A nor the B antigens. So they don't express any of these proteins on their surface. Now we have to be careful about this. There will be literally thousands of different proteins that can be expressed on the surface of red blood cells or other cells as well. But these are the two that we are concerned about with regard to blood transfusions, type A and type B. Okay, so an individual whose erythrocytes express the A antigen then have type A blood. Individuals who express the B antigen on the surface of their red blood cells are designated as having type B blood. Individuals who express both of these antigens, the A and the B antigens, on the surface of their red blood cells are designated to have type AB blood. If you have neither the A nor the B antigens on the surface of your red blood cells, then you're designated as having type O blood. Now, we have to move, remember there's two components to the blood. We have the formed elements and we have the plasma. So here we're seeing the formed element, the red blood cell, and this individual has the type A antigen on the surface of the red blood cell. How about in their plasma? Well, an individual with the type A antigen on the surface of their red blood cells will also carry with them in their plasma anti-B antibodies, antibodies against B antigens. They will not carry antibodies against A antigens. The reason for this is because if they had antibodies in their plasma and they have type A blood, if they had A antibodies, the A antibodies would attack the A antigens and cause their blood to clump, or we would say agglutinate. So they would not want the same antibodies or antibodies with the same designation in their plasma as their antigens. On the other hand, a person who has type B blood has B antigens expressed on the erythrocytes. They will not have anti-B antibodies now, but instead they will carry anti-A antibodies in their plasma. So if they had anti-B antibodies, and they had antigen B on the surface of their red blood cells, do you follow? That would cause their red blood cells to clump or to agglutinate and cause clotting or possibility of clogging the flow of blood through the vessels. So type B blood will have anti-A antibodies. You always have the opposite antibodies as the blood type. Now, moving to a person who has type AB blood, they remember express both the A and the B antigens. So they cannot carry either the A or the B antibodies in their plasma. They will not have A or B antibodies in their plasma. A person who has type O blood will have neither antigen on the surface of their red blood cells, so they'll carry both antibodies in their plasma. Okay? So, with that in mind, then, let's take a look at a situation where, let's say we have a person who has type A blood and they need a transfusion. Can you give a person who has type A blood a transfusion of type A blood? The answer is yes, you're giving them the same blood type. But can you give a person who has type A blood a transfusion of type B blood? The answer is no. The reason is because as soon as these red blood cells would enter the type A person's body, these anti-B antibodies would bind to the B antigens and cause the blood to clump, thus blocking blood flow through the blood vessels. It would essentially kill the patient. Okay, let's see if you're following along now. Let's say we have a person who is blood type B. That means they have the B antigens on the surface of their red blood cells. Can you give them a transfusion of A? The answer is no, because their anti-A antibodies would clump and destroy the A antigens in the blood they're receiving. Okay? Now, how about a person who has type AB blood? Could you give them a transfusion of type A blood? The answer is yes, because if you're wondering about this, because they don't have any antibodies in their plasma. So they could receive type B blood because they don't have antibodies to clump it. They could receive A blood because they don't have antibodies to clump it. Now, how about a person who is type O? Can they receive a transfusion of type A? The answer is no. The reason? They have anti-A antibodies in their plasma. that would cause the A blood to clump as soon as it enters? Can they receive a transfusion of type B blood? The answer again is no, because they have anti-B antibodies that would clump the blood as soon as it entered. Okay? Now, if we take this again a little bit further, going back to type A, can they receive B type blood? No, we already mentioned, because of the anti-B antibodies. Can they receive type AB blood? No, because they have the B antibodies would cause the AB blood to clump. Can they receive type O blood? The answer is yes, because the type O blood doesn't have any of the surface antigens, neither the A nor the B antigens, to react with the antibodies and cause the blood to clumping. So they can receive type O. How about a type B person? Can they receive A? Let's see if you're following along. No. Can they receive AB? No. Their anti-A antibodies would link on to the A surface antigens and cause this blood to clump. Can they receive O? The answer is yes, because no surface antigens to bind. How about the AB person? Can they receive A? Yes, they don't have any antibodies. Can they receive B? Yes, they don't have any antibodies. Can they receive type O? Yes, type O doesn't have any antigens and they don't have any antibodies. With that in mind, type AB blood is oftentimes referred to as the universal recipient. What about type O blood? Can type O blood receive A? The answer, no, it has anti-A antibodies. Can it receive type B blood? The answer, no, it has anti-B antibodies. Can it receive type AB blood? No, it has anti-A and anti-B antibodies. So, but one of the things we noticed here is that type O blood can be donated to type A because of the lack of surface antigens. It can be donated to type B because of the lack of surface antigens. It can be donated to AB because of the lack of surface antigens. For this reason, blood type O is oftentimes referred to as the universal donor. Okay, now the question becomes, how is blood type determined? Well, here's a video that I placed on Canvas under videos and animations called ABO/RH blood grouping systems. We're going to talk about RH here in just a minute and how to determine the blood type. I want you to watch that video and learn how blood types can be determined for the sake of transfusion purposes. That will be required and there will be questions on how to determine blood type on our next exam. Okay, so I talked about the clumping or agglutination. Here's what clumping or agglutination looks like. And again, agglutination is the clumping of cells in the presence of antibody. So for example, if these are red blood cells that have the A antigens on them, and these are A antibodies, the antibodies would link, this antibody would link to this cell and link to this cell and bind those two cells together because it would bind to the A antigens. And this antibody, again, if it's an A antibody, would link on to another antigen on this cell and an A antigen on this cell and cause these two cells to clump together. And you can see if this is repeated over and over again, how the cells would be clustered together and held together by the antibodies. This is referred to as agglutination. Here is a microscope slide, a digital image of what agglutination looks like. So we can see how the cells are starting to cluster or clump together here in this drop of blood. Well, the other component of blood type, and you may have been wondering all along about this, is whether the blood type is positive or negative. So we have not only type A, but A positive and A negative, B positive, B negative, AB positive, AB negative, and type O positive and negative. Where does the negative come from? Well, I think the best way to understand that is to take a look at a condition called erythroblastosis fetalis. This is also known as hemolytic disease of the newborn, or for short, because some people have trouble saying it, like me, HDN. But erythroblastosis fetalis develops in an unborn infant when the mom and the baby have different blood types. The most common form of erythroblastosis fetalis results from an ABO incompatibility. In other words, mom has type A blood, the baby inherits type B blood. That's possible depending upon the genetics of the father. However, in ABO incompatibilities, the symptoms are usually not all that severe. And there's a couple of reasons for that. One reason is that the blood cells of fetuses, while they're developing inside the mother's womb, don't express, even though they are type A, type B, type AB, they don't express a lot of those antigens at that time. So there's not a whole lot of binding that can occur. In addition, a second reason is because with regard to Rh factors, there are other, or excuse me, the ABO antigens. There are other tissues in the body, other cells that also express the AB antigens, A and B antigens. Not only red blood cells, in other words, but other cells of other tissues excuse me, can express the A and the B antigens. And so those other cells may bind up the antibodies and have very few antibodies remaining to bind up or cause agglutination of the red blood cells. So for those two reasons, if the problem is from an ABO incompatibility, it's usually not very severe. Less common, but more severe erythroblastosis fetalis occurs when there is an Rh incompatibility. And that gets us into the positive and negative. So, what does the positive and negative stand for? Well, if an individual is Rh positive, that means that the individual possesses anywhere from 1 to 6 additional antigens on the surface of their red blood cells, designated as rhesus antigens. These are separate from the A and B antigens. These antigens were first discovered in the blood of rhesus monkeys, and that's where they get their name. So if you, as an individual, express some of these additional antigens, there can be anywhere from 1 to 6, as long as you express one of them, you would be designated as Rh positive. On the other hand, individuals that do not possess any of these Rh antigens would be designated as Rh negative. So it's been studied, and the data shows that about 85% of the population is in fact Rh positive, does possess at least one of these 6 rhesus antigens. And so 85% of the population is Rh positive, but the other 15% of the population doesn't express any of these rhesus antigens. Therefore, those individuals are designated as Rh negative. So a person who's A positive expresses the rhesus antigens. A person who's A negative does not express the rhesus antigens. Now, what about the plasma? So if a person is Rh positive, they can't have Rh antibodies. floating in their plasma because the antibodies would clump the blood. But what about Rh negative individuals? Would they possess the Rh antibodies in their blood? Not necessarily. If they have not been exposed to Rh positive blood, they will not have the Rh antigens. So Rh, in summary, Rh antibodies in the plasma, the anti-Rh antibodies, or what we would designate as anti-D antibodies, only develop in an Rh negative individual when she is exposed to Rh positive blood, usually from a fetus. Now, this can happen in men too, but this is most important in pregnancy and fetal development. That's why I have she there. Okay, so here's the scenario. We have mom who's Rh negative, dad is Rh positive, and so as a result, the fetus now develops Rh positive because of the genetics that he receives from his or her dad. Okay? In this case, some of the Rh positive blood can leak from the fetus to the mother during the birthing process. And that could cause the mother to make Rh antibodies. This can be a problem if the mother has a second fetus then that is Rh positive, because she now has antibodies because of her exposure to her first baby's blood. She now has Rh antibodies, and those antibodies, if she has a second child, can now leak across the placenta and attack the fetus. So they can leak across that barrier between the mother's blood and the baby's blood, enter the baby's blood, and now begin to bind to the Rh antigens on the second developing fetus's blood. That would cause clumping, and that would cause the death of the individual, of the fetus. And it can, if it doesn't occur fast enough or early enough, it can lead to mental retardation at the best, and at worst, the death of the individual. So knowing whether an individual is Rh positive or Rh negative is also very important with regard to blood typing and transfusions. Okay, let's kind of wrap it up here. I've placed on the PowerPoint some other disorders of the blood. We'll go down through them rapidly and just make you aware of them. First one is anemia. Anemia is a condition that results from too few red blood cells or too little hemoglobin. And as a result, that causes a rundown feeling because the individual is not able to adequately transport oxygen to the tissues for cellular respiration. Next, we have leukemia. Leukemia is actually a group of cancers, various types, depending upon what type of white blood cells are affected. But the white blood cells are affected and in such a way that they begin to proliferate or grow rapidly without control. So the number of a particular type or group of white blood cells rapidly increases. Infectious mononucleosis is another disorder of the blood. It's also known as a kissing disease because it can be transferred through human fluids like saliva. This occurs when the Epstein-Barr virus, EBV, infects lymphocytes. This results in fatigue, sore throat, and swollen lymph glands. And then finally, we have hemophilia. Hemophilia is a genetic disorder that results in a deficiency of a clotting factor. So remember, we listed all those different clotting factors when we were taking a look at the blood clotting cascade. One or more of these factors can be not present, and that would cause a problem with the clotting of the blood. And this is referred to as hemophilia. so that when a person damages a blood vessel, they're unable to properly clot their blood both internally and externally. The challenge then for the medical professionals is to figure out what clotting factors are missing or not being produced and what's causing the blood not to be able to clot. The individual who has hemophilia then, if they have ruptured blood vessels or a cut or something like that, they're going to have to go to the hospital to have treatment for the hemophilia based upon what clotting factors they're missing. Okay, so that finishes our second screencast lecture on the blood. Please make sure you go back and take a look at those additional videos that I talked about and become familiar with how blood is typed. Have a great day, everybody.